Good morning. My name is Dr. Chris Towe, and I am a pediatric pulmonologist at Cincinnati Children's Hospital in Cincinnati, Ohio, where I direct the Rare Lung Diseases program. As part of that, serve as the primary pulmonary consultant to our Hemangioma and Vascular Malformation Center. Today I'm going to be briefly reviewing the pulmonary characteristics of lymphatic anomalies and how I, as a pulmonologist, approach these conditions. Disclosure: I'm a consultant for a pharmaceutical company, and of course I'll be talking about the off-label use of sirolimus and pretty much all other medications that I mentioned today. But we have outlined, we're going to briefly cover the central conducting lymphatic anomalies and how they impact the lungs specifically, and then we'll touch on generalized lymphatic anomalies and capaciform lymphangiomatosis, which I know we've talked about a lot in this conference. We'll talk specifically about some of the pulmonary manifestations of these conditions, and then we'll end by thinking about the impact of chronic pleural effusions and how they might impact our patients as they grow up, which I, as a pediatrician, take special interest in. So as I'm sure has been reviewed, the central conducting lymphatic anomalies occur when there's dysmotility or distal obstruction within the central lymphatic system. And this results in lymphangiectasia in multiple body parts, including the lung. This is a dynamic contrast-enhanced magnetic resonance lymphangiogram published by our chair, Dr. Itkin, the chair of today's session, Dr. Itkin, demonstrating these dilated lymphatic ducts. And when this happens, the pulmonary manifestations of this disease directly are chylothorax, but indirectly the loss of lymph fluid, specifically through the GI tract, results in hypoalbuminemia and also low IgG, which can result in recurrent infections if not treated properly. So from a pulmonary perspective, when I'm looking at patients with central conducting lymphatic anomalies, it's mostly supportive care that I can provide. If you have low IgG levels, you should receive IV immune globulin replacement up to normal levels. Because you're at risk for infection, you must aggressively treat these infections if needed. Albumin infusions in order to maintain osmotic pressure and reduce pulmonary edema. And obviously the treatment is done more by our interventional radiology colleagues through sclerosing lymphangiograms, which I'm sure is going to be talked about a lot in other sessions. Moving on to the generalized lymphatic anomalies. As we've discussed, this is previously referred to as lymphangiomatosis and is a multi-system disorder of discontiguous sites. In addition to the lung manifestations, which is primarily pleural effusions, there's bone abnormalities and lytic areas and other throughout the skeleton. You can see here one of our patients with a very, very large bilateral pleural effusion. And from my perspective, there's a lot of overlap and some similarities with the other disorder, capaciform lymphangiomatosis, which, as I'm sure has been discussed, is a variant, cousin, unclear relative of generalized lymphatic anomaly, but has the distinct feature of having thrombocytopenia and/or tissue hemorrhage. What does distinguish KLA from GLA is a vast majority, if not all, KLA patients have some pericardial mediastinal and/or pleural involvement. And the other big distinction about the pleural involvement is that the pleural effusion is frequently, if not always, bloody. Unfortunately, KLA, as we all know, has a very poor prognosis with a high mortality rate, and its pathologic characteristics is the spindled hemocytic lymphatic endothelial cells seen on biopsy. As I'm sure has been discussed in this conference, there's no standard treatment for either GLA or KLA, although sirolimus is becoming very widespread in patients who are not responding to sirolimus therapy and have appropriate genetic testing. The PIK3 inhibitors hold some promise. Other therapies are on a case-by-case basis and is dictated by severity and symptoms and can include corticosteroids, bisphosphonates, vincristine, pleural drainage, which we'll talk about in a second, with or without a pleural desis, and/or sclerotherapy. And then where I come in is offering supportive care from the respiratory insufficiency that can sometimes result from these significant pleural effusions. And this can be as simple as providing oxygen therapy, but sometimes can be more invasive, such as positive pressure BiPAP support. In my experience, a number of patients, specifically with KLA, because of the distinct inflammatory processes that are associated with it, some of these patients either have true asthma or other reactive airways disease and do benefit from albuterol and other therapies. So let's talk about these pleural effusions, because as we all know, in patients who have GLA or KLA, they are frequently chronic, and we frequently do not drain them because of the frequency of recurrence and the frequency of them just continuing to drain and drain and drain without an end in sight and an ability to pull the chest tube safely. And so to do this, let's consider a case of ours. This was a 7-year-old male patient who had what was thought to be generalized lymphatic anomaly. He may have actually developed KLA later, but that's outside of the scope of this talk. And when he was 7 years old, this was his MRI that showed a very large right and a moderate to large left pleural effusion that resulted in his lungs only functioning at about 33% capacity when measured in the pulmonary function lab by the forced vital capacity. He went to go visit Dr. Itkin and received pretty aggressive intervention in sclerotherapy. And 2 years later, we saw him again, and his imaging had drastically improved, and his forced vital capacity had also almost doubled in size to 56% of normal. And so the question that we had, and I'm sure this child's parents, is, okay, so now what is the impact of his lung being squashed by pleural effusion for years and years and years, and then we suddenly re-expand it? Does this lung function like a normal lung? To answer this question, we did a research study on him. He graciously agreed to participate in one of our xenon-restricted diffusion MRIs. And to do this, we have the patient in an MRI scanner. We take a bag of hyperpolarized 129 xenon, and we have him inhale the xenon particles. And the xenon particles traveled all the way to the alveolar space. And the alveolar space is supposed to be small and symmetric in size. And we can measure the diffusion of these molecules within that alveolar space. Contrast that with somebody who has abnormally dilated alveoli, like their lungs were squished and now they're massively expanded. And so did they dilate their alveoli by doing this? And we can measure, and we would see a larger diffusion coefficient. So in this patient, we did an MRI, and the first two sequences of imaging look very similar to conventional MRI, showing the bilateral pleural effusions. The arrows become important in a second. And then once we had him inhale the xenon, we were able to do two different imaging sequences where we could show in the third row of images his ventilation, i.e. just where did the xenon gas go? And you can see that his lungs light up bilaterally, and you can see the same spots that had residual pleural effusion had diminishment in ventilation. But what we were really looking for was this, and this is a heat map of his alveolar sizes on a voxel by voxel, i.e. on a point by point measurement. And we were able to show that his xenon apparent diffusion coefficient was 0.29 centimeters squared per second, which is similar to other age-matched controls, which implies that his alveolar growth, even though it was squished and restricted for many years, is normal. So in conclusion, good supportive care is necessary to optimize lung health and minimize infections while we go about treating the underlying cause. Multidisciplinary teams are necessary for the management of these complex patients, especially when you have multi-system involvement. And future studies are definitely needed to determine the impact of chronic pleural effusions on lung growth and development as we work towards the day where all these patients are treated successfully. So I would like to thank the organizers for giving me an opportunity to participate in this conference. I'd also like to recognize our multidisciplinary team from the Hemangioma and Vascular Malformation Center, along with my nurse and admin who helped me run my life, and the Center for Pulmonary Imaging and Research who did this MRI study. And in case you were paying more attention to the picture behind me, I gave you a blow-up of it so that you know what it actually looks like. Thank you, and I look forward to the discussion.